Hello and welcome to another episode of Melbourne Athlete Development Podcast. Today, I'm very happy to have a guest, Dr. Jacques Courseault. Jacques, do you want to introduce yourself and just discuss who you are, what your background is, and what you do?
Sure. First of all, thanks for the invitation. It's amazing how interesting this article is. They were talking about how popular it's gotten in the past year or so. But I'm a physician, a sports medicine specialist. Practice at Tulane University School of Medicine in New Orleans, Louisiana. And I'm the founder and medical director of the Fascia Institute and Treatment Center. My background is in physical medicine and rehabilitation, with an additional certification of training in sports medicine. And I'm a consultant for various professional sports teams. We take care of many high school teams. I'm a team physician for Tulane University. So we have a wide breadth of experiences. Never did I think I'd be into genetics and biochemistry, but here we are talking about this paper, and I'm excited to be here.
Well, it'd be interesting to discuss how you got to this point then too, because the article we're talking about specifically is your recent publication on what's called folate-dependent hypermobility syndrome. So what actually motivated you to explore this area of research?
It's just one of those things in life that you come across and you really notice patterns and can't ignore what you see. So, like I mentioned, biochemistry in medical school, I did what I could to just get through that class, and the same with genetics. Interesting, but really not my forte. And practicing sports medicine in an academic university in New Orleans, you tend to see a lot of very complex cases, and you get referrals for complex cases. And my specialty in particular was in myofascial treatment, non-operative injuries, and pain control without medications. And so I started getting referrals for patients with diagnosed Ehlers-Danlos syndrome, and they would come into the clinic and say, "Hey, doc, look, my shoulder can pop out and my hip can pop out, and I'm 60 years old and I can put my legs over my head and do a split." And they were referred for myofascial pain type treatments. And it was interesting that most of these patients didn't do well with pain medications that they had tried from other doctors, and generally didn't get numb with local anesthetics. So it's a bit of a challenge, but I treated initially my practice with trigger point based injections that seemed to help. At the same time, I was still practicing heavy sports medicine and musculoskeletal pain treatments, and really realized a pattern of, hey, this person also has POTS and allergy issues and thyroid issues and multiple pain issues and complex surgical complications. And so then I started asking these patients, that were just referred for mild fascial or MSK complaints, hey, how flexible were you growing up, or are you flexible now? And the majority of them said, yeah, how'd you know? And then I realized, wait, these are the same group of people that are being referred for Ehlers-Danlos syndrome. And so my first reflex response was, hey, well, let's send them to an Ehlers-Danlos clinic. And we couldn't find any. There are many genetics-based clinics out there, but very few comprehensive multidisciplinary clinics. So my nurse at the time, who through her experiences also discovered she was hypermobile and had many of these same issues, decided to start a clinic. And we started a Facebook page, and within 3 hours of posting, we were booked for 6 months. And so here I am, probably 3.5 years out, with about a 3-year waiting list and about 1,500 new patients pending to be seen.
Yeah, wow. You mentioned that you started noticing these patients often having other conditions. So POTS, I'm assuming you're referring to postural orthostatic tachycardia syndrome there. And
Yeah,
was it mast cell activation was the other one? Did you say too?
correct.
So these different types of presentations, do they have similarities in terms of some of the underlying pathology? Because I'm assuming they have correlations to things like folate deficiency as well, or was it just more you thinking, okay, there seems to be a common pattern here? Is there an underlying, say, genetic polymorphism or something else that's involved?
Yeah, so So once I started seeing these patterns, I did my share of research, and there's relatively good access to research. I mean, the EDS Society has great videos. There's local geneticists that I spoke with. There's a few from around the country that I called and say, "Hey, what is this? Can you teach me more about this?" And it seemed to be kind of the trifecta of, you're somewhere on the spectrum of flexibility. Some people are ridiculously contortionist level flexible. Some people are more flexible than they should be. When it comes to dysautonomia, subset postural orthostatic tachycardia syndrome or POTS, so different gradings of that. Some people tended to get lightheaded and pass out almost, well, not really fully pass out, but get extremely lightheaded every time they got up. Some just, yeah, I've never thought about it, but when I do get up, I do see spots and drink some water and it goes away. So there's a tremendous spectrum on the POT scale. And when it came to allergies, MCAS just received its, ICD-10 diagnosis in 2017. So there's, from what I understand, I'm not an allergist, immunologist, but a lot of debate amongst those professionals as to what the diagnosis of MCAS actually entails. And it's a pretty strict research grade, which is a research level diagnosis. But on that spectrum are allergies and people with histaminergic type responses to medications, foods, wavelengths of light. Actually called, oh, shoot, I'm blanking on his name, Occam's Lawrence Afrin. I can't believe I'm blanking on his name, but I spoke with him for a few hours about MCAS, and it was all very interesting. So I just decided to do my own research and make my own observations. But a lot of that's on the spectrum too. So, we decided to start treating these patients with relatively safe treatments and see how they responded. In that process, I said, what else can be causing, this subtype of Ehlers-Danlos syndrome, and kind of going towards that. There's 13 total subtypes we know about. 12 of them are pretty clear genetic base, extracellular matrix, collagen based disorders. But then there's a hypermobile subtype, which has a lot of debate as to what that entails. The excellent work done by the EDS consortium in attempting to define exactly what hypermobile EDS is in order to promote research and further identification of that. So we're pretty strict with whether or not patients meet that criteria. In that process, we developed a panel of lab work, which included folate and B12 amongst others, and notice a pattern of, these folate levels are off the charts. Why is that? These B12 levels are off the charts or ridiculously low. Certainly, there were a few that were normal. Then I started noticing a correlation of people with elevated folates and past medical histories of MTHFR polymorphisms, which, again, that's another area of tremendous debate as what the relevance of that specific polymorphism entails amongst multiple areas of medicine, from heart disease to OBGYN issues, and just started throwing that in the panel of labs that we checked, and noticed that a large percentage of our population, in comparison to published journal population prevalence, was significantly higher. So then further research and discussion with Greg Biggs, our Tulane biochemistry neuroscience specialist, and geneticists, as well as hematology, oncologists, say, well, what do you do to treat folate processing issues, particularly those with a decreased enzyme? The answer was, you address the methylation cycle with methylfolate, methyl B12, choline, and see how people respond. Most people, and this was advice given to me, most people respond, pretty well when you treat them. Some people have adverse reactions. Some notice really not much of a difference. And so we decided to look more into that. It turns out, I was working with Greg Bix on another project related to COVID long haul at the time, and realized that he was highly familiar with a protein called decarin. And the decarin is an extracellular matrix protein. When we look at decarin knockout mice, they're certainly basically fit the description of classic hypermobility type of person. Hypermobile, bruise easy, allergic responses. There were certain other rat-based characteristics that we could really correlate with humans. So then decided to trace the biochemistry behind that and develop this hypothesis correlating decreased intracellular folate levels or activated folate levels to elevated MMP2, which would eventually break down decorin and cause disorganization of this extracellular matrix, which, of course, there's plenty of work steps to be done, but from a bird's eye contextual view makes sense because we realize that hypermobility spectrum disorders and hypermobile EDS are not collagen problem disorders. It has to do with the way collagen is organized. Or what's the gel that organized collagen was the complex proteins in the extracellular matrix. And this one protein that we were able to identify and tie to folate metabolism issues seems to be relevant.
Mm-mm. There's probably a lot we should unpack there because there's a few things that you've brought up that I think a lot of our listeners, even including myself, in terms of um, may not being aware of things like methylation, let alone actually really talking about the relationship here about, say, nutrient factors impact on genetics and genetic regulation and how that leads to something like hypermobility syndrome. So, would you be able to just briefly explain what methylation is, and then talk about how some of the key nutrients, such as B9 or folate, are involved in the methylation process?
Yeah, it's really interesting. Again, I didn't think I'd be that interested in biochemistry, but when you look at the methylation cycle and talk to methylation cycle experts, which we reached out to many internationally. When I say many, I'm joking because there's really only a few people that have spent decades of their careers researching this, but they were excited to hear from us. But methylation is really important. I didn't realize how important it was. A methyl group is basically a carbon and three hydrogen group at the most basic biochemistry level. But those methyl groups are needed to activate many billions of chemical reactions in your body per second. When you look at what methylation is implicated in, it has to do with genetic regulation, has to do with many biochemical processes, has to do with detoxing medications, activating certain medications, neurotransmission, enzyme regulation, hormone regulation. So it's basically kind of a ubiquitous thing, and if that cycle is impaired, then it would make sense that it would lead to multiple symptomatic medical issues. Some of them which can be confusing, and a lot of them which do have overlapping characteristics. But it's a very important cycle, and if it's not running the way it needs to, then you see these clinical problems. What's interesting is that there are many different pathways into the methylation cycle. Amongst the most common ones are going to be folate or methylated folate. B12 is implicated. Choline is another one. So these certain dietary mechanisms certainly can affect the way your methylation cycle works. If there's certain stop points in your methylation cycle via enzyme deficiencies, then you can have certain proteins that are elevated, like homocysteine, for example, they can't get converted. Um,
Mm.
and like I said, it has a lot to do with DNA regulation. What actually is tied to this discussion is bringing in folic acid, which is synthetic. Um, in Western society and certainly other parts of the world was introduced to foods to prevent neural tube defects, which is a dysfunction in spinal cord in newborns, in the spinal column in newborns. And it certainly has helped decrease the rate of neural tube defects. But I think there's many mechanisms that we described in the paper in which folic acid, we hypothesize, can cause other issues um, to some extent related to those with hypermobility syndrome. So in a nutshell, the methylation cycle is something that we should all probably be paying more attention to. There's, I think, relatively simple ways to check it. And as far as treating pain disorders, hypermobility disorders, POTS, mast-cell issues, that's probably a good place to start.
Mm. Because methylation or genetic polymorphisms associated with methylation are quite prevalent in the general population. Yes, there's a lot of different polymorphisms that can lead to essentially a downregulation of it. Is that correct?
And so it depends on which population you look at. I mean, we quoted in our paper about a 35% prevalence in general population. In our population, the prevalence is much higher than that.
Mm.
That publication should be coming out pretty soon, but there's a market increase in self-selected hypermobile patients that we check for MTHFR polymorphisms.
So, with some of the clinical work that you're doing, are you thinking that when someone does present with hypermobility, particularly if they're symptomatic, whether they, for instance, have recurrent, say, dislocations or subluxations, or I imagine a lot of the time they also present with just more general, non-specific myofascial pain. Do you think we need to be looking a bit more deeply then into, say, their potentially genetic profile or looking at their biochemistry to see if there are alterations in their, say, folate or B12 metabolism?
Yeah, I think so. We've certainly seen improvements in most of our patients, not all of them, that, sometimes come in with just myofascial pain and don't realize that hypermobility is something that they should be aware of. And, addressing it with supplements that have been around for a while and are safe tends to be important. What we're looking at is not just hypermobility. I think a lot of this does apply to the general connective tissue disorder category.
Mhm.
That overlaps with other autoimmune disorders as well. I mean, there's many other autoimmune disorders, rheumatoid arthritis, lupus, Sjogren's, that have a large proportion of hypermobile patients, if not most of them. So it's not, there's a lot of overlap in what we're doing as far as looking at the biochemistry of it. But it is prudent for clinicians to check lab work and, make these supplement recommendations, just like we do with vitamin D, which is probably implicated in connective tissue disorders, just like we do with vitamin C, just like we do with magnesium. I would throw folate and B12 in those panels, and if possible include the MTHFR polymorphisms, because serum folate and B12 levels don't always tell the whole picture. This is going to get thrown off by um, high or low serum folate and B12s, and a lot of that is based on what the patient's intake is. And there's certainly other genetic polymorphisms that could be implicated in hypermobility that we haven't even really begun to take a look at.
Mm. When it comes to diagnosing someone who maybe has some type of hypermobility syndrome disorder, what kind of clinical assessments do you go through? Are you looking at just some of the key um, range of movement assessments when you think about, say, like elbow hyperextension, knee hyperextension, looking at, say, thumb mobility, or are you also including other forms of assessment when you think about, say, like looking at the actual connective tissue structure under ultrasound?
Yeah, so that's an interesting question. I mean, to be not so humble, I can almost walk in the room and tell. A lot of times people will sit on their legs, and you're like, okay, we already know where this visit is going. Um,
Hmm,
Dilated pupils tend to be a part of this. Wing scapula. You can usually tell if someone has scoliosis by the way their shoulders sit. Um,
hmm,
in the summer, it's 100 degrees here in New Orleans, and you see a patient with a tank top on, and a lot of times you can see the sulfate sign in the shoulder. Thin skin
hmm,
is easy to identify. Vitiligo is associated with folate metabolism in a few studies that I've looked at. So a lot of times a general clinical observation, which I think a lot of times we don't always do the best job of, but just walking in and knowing these kind of overlying contextual characterizations already has your mind kind of joggled in one way or another. But then we get to Baton's criteria, which I think is a great place to start. I mean, there's certainly flaws in looking at Baton's criteria, but pinky finger bent back 90 degrees, thumb to forearm, elbow hyperextension, knee hyperextension. Can you touch the floor? Do your knees hyperextend? Are certainly the most basic clinical findings. There's caveats to that. With age, the score that you have to meet drops. Injuries can also come into play with this. So MSK clinic, sports medicine clinic will have, middle age, older athletes that are really arthritic from their sport and tend to not be as hypermobile. But when you ask them historically, were they hypermobile, then they would definitely tell you yes. There's certain people that have fascial adhesions and thickness that were once hypermobile, but they're now tight in their hamstrings, so they can't really touch the ground. So you do have to dig deeper and just can't, really do a screen and say, oh wait, you didn't meet the 5 points, you're not hypermobile. So there's a larger contextual to that, and then after that, you get into looking at things like you mentioned, imaging modalities, which we published on the high incidence of cervical medullary syndrome or claviaxial angle uh, decrease in patients' hypermobility. Certainly, cervical instability has been implicated in this. Scoliosis has been implicated. Early stenosis, um, gap of the winging. So there's other objective findings that you can look into, depending on how much you want to look into this and dig deep to prove diagnosis. But I think also knowing range of motion and what's tight and what's not can help you treat these patients and put them on the path they need to improve and feel better.
Mm. So actually then discussing more about the management of a lot of the patients you see, are you looking at mainly doing dietary adjustment or supplementation? What kind of things are you actually applying to try and change their, I guess, methylation cycle that then impacts their connective tissue metabolism?
Yeah, so it depends. I mean, our intake form is probably around 90 questions. Um, Pretty much anything that we can ask about history, um, physical history, traumatic history, what's been done, did PT work, what was done in PT, we're doing any OT, have you
Mm.
seen a nutritionist, what does your diet entail? So it is a process that takes many months to get through. We have great physicians in our team. We have cardiologists that do evaluations. We have allergy immunologists, a nutritionist that basically sees all of our patients. We have excellent hypermobility-based physical therapists. We have internal medicine doctors, dentists, psychiatrists, social workers. So it's a great team that we built here in a network-based kind of system. But every patient comes with a different need. They come with a different set of lab values. They come with different polymorphisms, particularly the MTHFR gene, and really each case needs to be treated on an individual basis. So there really is no kind of one size fits all. Um, as we've learned, those with the A1298C polymorphisms and inability not to present with as many symptoms as those with the homozygous C677Ts do. But again, a lot of that does, depend on environment and lifestyle. You can have your homozygous C677T patient who's a yoga instructor who eats organic food. Um, at some point found out that they had an MTHFR polymorphism and has been taking methylated folate and B12 for years, and they do really well. And they say, look, I kind of pulled my back or my hamstring, and we do a treatment of usually fascial-based treatment for that. They do great. And then on the other end of the
Mm.
spectrum, you have, a heterozygous A1298C that has severe POTS, it has mast cells that are out of control, pain everywhere, unhealthy diet, unhealthy lifestyle, and everything needs to be addressed. So it does get complex in that sense, and it's hard to put together a protocol, so to speak, because everyone presents so differently, and a lot of it does have to do with
Mm.
genetic factors, and I think we're just scratching the surface when it comes to looking at the coding of different proteins in the extracellular matrix and how collagen is affected, and then it's not just that. Then you look at other factors like tryptase and hereditary alpha tryptasemia, which is associated with hypermobility and probably a subtype. The tryptase does break down collagen and probably does cause extracellular matrix weakness. So it really does. I enjoy it because I come to work every day working, and it's like playing detective on how to figure it out and make sure that we're not over-treating, under-treating. But I do believe that, if you don't address the soil, the biochemistry soil that you're working in, then it does create a bit of a barrier to helping your patients improve.
Yeah, I think the thing you highlight there too is I've actually had my genetic testing done myself, and I know I have some genetic polymorphisms associated with MTHFR regulation. But then understanding that I know I've heard a quote before that genes load the gun, but the environment pulls the trigger.
Yep.
And so you can actually have some of these polymorphisms, but actually be completely asymptomatic based on some of those environmental factors. And obviously, like a big one that you've mentioned is related to dietary factors, but I'm sure there's many other things that also then regulate our epigenetics specifically.
Yeah, I mean, it's
So,
it really is, and thinking, and I think that's why we include, amongst many reasons, that's why we included nutritionists dig deep into, like, what is your fluid intake? Are you taking electrolytes? What supplements are you taking? This supplement might be bad. How are medications affecting your metabolic status? What is your lifestyle like? Are you an attorney that sits in a desk and on a computer all day?
mm,
Or are you a personal trainer? So all those things do come into play. Just because you have a polymorphism doesn't mean it's the end all of your life. There's probably certain advantages
mm,
to being. There's certainly certain advantages to being hypermobile. Probably certain advantage to having a
mm.
MTHFR polymorphism. So not everything fits into a nice, pretty picture, which can be frustrating, but it does make for the need for individualized treatment.
Is there any indications from the research that there is a higher prevalence of people, say, suffering from hypermobility? Like, is there something? I'm just wondering if there's things that are changing in our environment that are leading to altered expression of, say, these polymorphisms that are manifesting in more, say, myofascial pain or hypermobility
Yeah,
disorders.
I mean, that's an interesting question. The MTHFR polymorphisms are autosomal dominant. So, as there are more generations, the prevalence itself will increase. I do think that there are genetic factors that are affecting symptoms associated with this. I mean, the one that comes to the top of my mind is probably folic acid. The folic acid, and we described that to some extent in our paper, can block folate receptors and impair uh, the introduction of activated or methylated folate into cells. So that's certainly an area of research that needs a bit more of attention. But you're right. I mean, lifestyle makes a difference. Processed foods are
Mm,
not beneficial. What is the quality of the fruits and vegetables that we eat? Are we getting the C's and D's that we need? Green leafy vegetables are apparently high in folate, but they probably need to be fresh out the ground or immediately flash frozen to maintain those folate levels and not cooked at high temperature. So the things that we're doing um, from a society standpoint are probably making people more symptomatic. Um, and then I think the other part of it too is lifestyle. Those who come into our
mm.
clinic that are athletic, not overuse athletes, but regular athletes, uh, tend to do well. Those who overuse tend to have problems, and those that don't exercise at all tend to have problems. So yeah, there's many things surrounding, like I said, your genotype that can affect how you present from a symptom standpoint.
And I think that's a point worth highlighting too. You mentioned, say, folic acid, because I think of, say, when you think of folate, particularly when you think about supplementation, it can come in many forms. And so I think nowadays a lot of foods are fortified with folic acid, but that's actually a synthetic form that you're saying that may actually have complications because it can block the receptor and therefore its function and ability to, say, bind methylfolate, which is the more active form in the body. Is that
That is
correct?
correct. Yes. And
Yeah.
it's interesting, because it's a natural inclination, when you're buying rice. Okay, let me buy brown rice because it's healthier. And then you look on the shelf and you see, oh,
Mm,
fortified or enriched brown rice. You're like, oh, that's got to be great. Well, it's got 10,000% daily value of folic acid in it. So why do you think you're doing something
mm.
beneficial for yourself? If you have a polymorphism, and maybe even those without it, we can be causing more problems than good. The other things that are causing issues in society are energy drinks. that are fortified with
Hmm.
like insane amounts of B12, insane amounts of folic acid. Um, so those probably need to have a formulation change as well. But yeah, I mean, really paying attention to nutrition labels, looking for folic acid can potentially make a difference. And I've had many patients that said, "Hey, once I cut that out, like my GI symptoms got better, I had more energy, my cognitive brain fog improved." So certainly worth pursuing. The only caveat is that if you're trying to get pregnant, you need to have some folate supplementation in your system. Um, from my
Mm.
experience, and there's early research suggesting that methylated folate is superior, but there certainly needs to be more investigation into that.
What about food versus supplementation? Because I think about with food too, I've heard this discussion about whole foods have the food matrix, and you have all these other cofactors, whether they're vitamins or minerals, that are typically associated with the uptake and utilization of that particular nutrient. Is that something that you also recommend the patients you see in terms of eating folate rich foods? And if so, what kind of foods are things that are useful to consider?
Yeah, certainly. Like I mentioned, we send everyone to a nutritionist that spends time developing a specific plan for the
Mm,
symptoms that they have, the genetic polymorphisms that they have, any other vitamin deficiencies that show up. So, I don't think it's one or the other. I mean, I think we all generally need to have good whole food organic diets. And certainly there are certain
mm.
cofactors and enzymes that when consumed with vitamins and minerals help with absorption. And I fully I fully believe that. Um, it doesn't hurt to supplement with methylation. The caveat to that is that the quality of the supplement, I'm pretty sure does matter. The methylfolate you get from the corner gas station is probably not as good as research grade supplements. So while some of the things can cost you a little bit of money, when I tell my patients it's worth investing in your vehicle. But we do encourage both. There's sometimes you get your supplements or you're like, I'm over taking this stuff. So that's when your diet has kind of a backup safety net, and vice versa. You can not. I don't think many people are absolutely great with their diets. It's still good to kind of have this supplement backup safety net. But yeah, I mean, what you eat when it comes to hypermobile symptoms certainly are relevant when we talk about histamine in foods, when we talk about GI dysfunction and how to regulate that, when we talk about fluid and electrolyte intake. So all those things really matter, and I think you have to address the whole picture in order to really get people feeling better.
So I imagine, given the complexity of how, say, people with say hypermobility are presenting, because they might have multiple symptoms related to other systems in their body, and you're taking this tailored approach to understand what are the key things we need to address. When you go through treating these patients, what are the big differences that you're seeing? I mean, I imagine it manifests in many different ways because they might get, say, improvements in things like, say, GI function as an example, or issues, less histamine, um, excessive histamine as an example. But what about from the musculoskeletal perspective? Are you seeing quite significant changes then? I'm assuming like in things like pain, but do you also see a reduction in things like dislocation rates or even actual indications of hypermobility as the connective tissue remodels?
Um, I see differences in fascial fibrosis on ultrasound. And so we do
Mm,
hydrodissection treatments and regenerative types of treatments, and actually published some ultrasound images in the paper. Um, but patients with back pain, for example, you know, and I go down the path of like my thoughts on back pain, but that's a whole nother conversation. Most back pain, in my
mm,
experience, is fascial related pain. And when we look at it with ultrasound, you can see extremely thick fascia, the thoracolumbar fascial complex. And with treatment and time and regulating the methylation cycle, the fascial planes do normalize themselves. And I also suspect there are increased increased tissue stiffness, which is a whole nother area of research with this. I don't see, I guess it's hard to say if addressing methylation itself was resulting in decreased dislocations. Um, I think the decrease in dislocations that we're seeing is multifactorial. I mean, when you're learning not to go out of normal range of motion, when you're doing isometric strengthening, you're working with a PT, you're wearing posture garments and compression leggings, and I think those things are probably reducing dislocations more than what we're doing from a biochemical perspective. But we are seeing decreases in pain too. And I think a lot of that's probably neurologic. Again, the nerves are probably highly dependent on methylated B vitamins to function correctly, which is why neuropathy is treated with B complex. So I think it is multifactorial, but I don't think it's as simple as like, hey, I'm taking methylated folate and my joints are not dislocating anymore. It's way more complex than that.
Sure, sure. Are you familiar with some of the work from Carla and Antonio Stecco in looking at things like myofascial pain and densifications?
I've scratched the surface in researching that, but I'm not thoroughly familiar
Yeah,
though.
no, the reason why Yeah, okay. I'm currently doing a 3-year training program in fascial manipulation, which is with the Steco group. And, you're talking about some of these tissue changes makes me think about some of the things I'm learning in regards to, as you mentioned, like the prevalence of myofascial tissue within a lot of pain disorders, particularly, say, chronic non-specific back pain or neck pain, and thinking about some of the changes you see over time and how that can actually be seen on potentially on ultrasound as well in terms of one thing like the thickness, which I know is something that you've discussed, but also then like how that affects the sliding
Hmm.
mechanics of the different sublayers of fascia. Yeah, no, I think it would be interesting to see if you two ever actually intertwine, because I think there'd be a lot of interesting stuff for you two to share.
Yeah, the World Fascial Congress is actually be in New Orleans in 2025. So I'm excited to meet other people that are interested in this because for the longest time, in New Orleans, there's a few people that are interested, and I think that's in America in general. I think Australia is a bit ahead when it comes to the PT and looking at fascia and how that's related to certain disorders as well as the UK. So I'll be the bad American and say we're behind on that, unfortunately. But I think there's a huge shift looking into that. I think the technology is better. Education should be improving. Of course, there's a big push to limit opiate use, and so we have to do something. And I think this is the appropriate thing. I mean, just masking pain, from my perspective, really isn't a good way to treat people, especially with all the dangers and side effects associated with certain pain medications. So to actually address
Mm.
the problem to me is extremely rewarding. But I can't wait to actually get to a point where we're sitting down and just having discussions on fascia. And there's major fascial conferences, and it's an everyday term that people understand.
And it's the forgotten structure. I mean, look, even in Australia, I still feel like we're very muscle centric and very joint centric, particularly when it comes to pain conditions. But yeah, I think like that gap is slowly being bridged, and you bring an interesting point up here because, well, sorry, an interesting question I want to ask you is, what is it about you that got you curious into actually thinking more at a deeper level about what's going on here? Because I think very often for many physicians, clinicians, they're very protocol driven with how they treat a problem. Someone comes in with myofascial pain, here's the standard protocol. But you've really gone the next step to understand, well, what's going on here? And I'm seeing certain patterns between how these people are presenting with other conditions. Is there something else that we're looking at that we need
I
to
think
look
the
at?
key is to touch the patient. There's so many doctors that don't touch
Mm,
patients. You walk in, say, this is what your X-ray looks like, this is what your MRI looks like, and this is the problem. In most of these cases, you touch somebody, you gently push on a lumbar paraspinal muscle and say, ouch, that's it. That's the problem. It's not a bulging disc, a herniated disc, and certainly if there's no neurological
mm.
symptoms, you push on a glute, trapezius, rhomboid. That's the problem. At least try to address that first because those treatments are much easier than treating axial skeletal issues or joint issues, and certainly safer than getting into joints and the spinal canal. So to me, I don't know if it's just, I had really good training in my residency, so I have to kind of give a shout out to my attending physicians there. But a lot of it is common sense. Point to where you hurt. Let me push on it. Ouch. Okay, well let's see if there's something on the surface that's the problem.
Mm. I think sometimes just using first principles is forgotten of, and actually thinking about that individualized approach of just giving someone a label. With that in mind, though, I think one of the issues or limitations at the moment with people uh, adopting understanding fascia as a source of pain and dysfunction, of how we can actually image that or quantify that. Are you looking more into how you can do that? Like, I know you've talked about doing ultrasound imaging. Are you finding that you're able to very consistently see differences between, say, normal and symptomatic groups? And are you using any other type of imaging to try and quantify fascial changes and its relationship to someone's
Yeah,
presentation?
I mean, at the Tulane Fascia Institute, we have a lot of research ongoing, that's looking at fascia and
Mm,
its in a relationship with many other aspects of the human. There's an excellent book. It's a fascia textbook written by Rob Slipe that I highly recommend that people read. That discusses nutritional aspects of fascia, about mechanical makeup of fascia, the biochemistry of fascia. Um, so
this is a fascia in sport and
I think
movement.
that's
Is that
it.
the
Yeah,
one?
the black book.
Yeah, I've got that
It's a
textbook
fantastic.
literally. Oh, there's also
Yes,
the tensional
I think
network of
I
the
think
human
it's that
body
one.
too.
Um,
Yeah,
so you know,
I've got those two books just
he's a
above
he's a
me.
great pioneer when it comes to that, and I think him and those before me who really, like Tavel was, probably the one everyone knows, for looking into this and looking at trigger points, and really making people aware that, hey, not everything is just, so like you said, procedural, cut and dry. That the fascia network, which connects
Mm,
organs and muscle and bone and neural tissue, is all interrelated. So people say, when you push on my shoulder, I feel it in my toe. But they're probably telling the truth because it's all
mm,
connected. So
mm,
there's other, treatment modalities that were, way ahead of this, many centuries ago. When you look at acupuncture and certain massage techniques that have been done, it's like, why am I sticking my knee to help, my stomach feel better, for example? But now I see
mm,
why, because when you
mm,
actually look at fascia and trace it with ultrasound, it's really all connected. So it's just a matter of, probably many decades of research to quantify what's normal fascia, what's abnormal fascia, then that's just on the macro part of it. Then you look at, what are in these fascial planes, what's the makeup of these individuals. So I think things can get really complex, but and I'm glad that there's a movement, look more into fascia from a holistic perspective, and it's not just the stuff that you throw in the trash when you do an anatomy dissection. It's highly relevant to
mm.
the human.
Yeah, well, yeah, it's that issue of anatomy is dependent on the anatomist, and so many anatomists cut away the fascia to make muscles look like independent actuators, which in fact is an illusion. We have all these myofascial expansions and continuity, and I think like you really highlight the point there, where I think for the amount of people who, for instance, experience referral pain down their leg, and there's always the assumption that it's radicular in nature, some type of say nerve root compression, but the prevalence of myofascial referral pain is so high, yet often gets undiagnosed. And then, there's obviously the consequences of treating the wrong thing.
Yeah, I mean, I couldn't agree more. I mean, if I hear sciatica one more time, I'll scream. I also do EMG, nerve conduction studies. So, if someone has a true sciatic neuropathy, we can check for it. And out of the many thousands that I've done, I've probably seen two cases, and both of them were traumatic. I mean, one was a gunshot, and one was a knife wound. And when you think about it, you and
Oh
I are
wow.
sitting on both of our sciatic nerves right now. And I don't know about you, but my legs are not going numb.
Mm.
And when you look at cadaver dissections and you look at ultrasound, I mean, that sciatic nerve sheath is really thick. I mean, it's almost like bone. Um, So, that lends
Mm,
to the fact that a lot of pain is myofascial and it's referred, and Terrell and Simons have described this pattern, and you see them clinically, and we just need to base more of our treatments on muscle and myofascial issues. And if those things don't work, and then you go down the processes of EMGs and MRIs, and it's true radicular stuff, then you can address it that way. But in most cases, in my experience in my clinic, tend not to be radicular.
mm. Another publication you've done in, I think it was in 2019, was the paper Fascial Hydrodissection for Chronic Hamstring Injury. And you actually did mention before about using hydrodissection. Could you actually explain what that is and discuss the article and actually when you apply it
Yeah,
clinically?
so it's really interesting again how we kind of came across that. I used to do a lot of trigger point injection for athletes with hamstring strains, and with those you just kind of guess and hope for the best. We then started using ultrasound.
And what kind of injection would you be doing? What kind of injection would you be doing? What would
Yeah,
the
so
solution
usually with
be?
trigger point, it's going to be a local anesthetic and a steroid. Sometimes a saline-based solution, but in
Mm,
general, it's a local anesthetic and a steroid. And so then I decided to say, let me use the ultrasound and see what the heck I'm injecting. And it turns out that the successful injections were those along fascial planes. That really led to a lot of improvement in symptoms, and it's improved flexibility, it's relatively immediate pain relief, and it's return to play typically within a week. And so we had a nice series back in
mm,
2019 of this was 3 or 4 athletes that went back to play in 3 or 4 days. That did really well, and so we've been doing hydrodissections on a regular basis from like pro athletes to the 50-year-old runner who took a bad step, and get people back. So I think the ways of 6 weeks for hamstring recovery are outdated, and there's ways you can get people back. And of course, it's in the
mm.
context of proper rehab. I mean, we do what we do from a procedural standpoint, but it does take an excellent PT or athletic trainer to safely get these athletes back without having a re-injury.
So actually, just to explain the kind of patients that you find this effective. So this is someone who's, say, for instance, suffered a hamstring strain. They're going through their normal rehabilitation process, but you're then looking at, well, are there some changes to some of the, say, fascial sliding on the interface where it becomes a little bit, say, stuck or fibrotic that's contributing to this ongoing symptoms or potentially hamstring dysfunction?
Correct. Yeah. So, I mean, it is a highly specialized kind of ultrasound technique, and it takes a lot of experience to see you have to look at a lot of normal tissues to identify what's abnormal, and then correlate it with what you find clinically.
Mm,
But a lot of times we see adhesions between the semitendinosus and adductor magnus, or semitendinosus and semimembranosus and ST along the biceps. And you can actually, the benefit of dynamic ultrasound is you can see how the tissue moves, and decide to do treatments based on the movement of the tissue and where suspected adhesions are. So they try, it does take experience. You have to be careful of the sciatic nerve. You have to know your anatomy, and you just have to have
mm.
a feel for, which the right type of injection, how much do you inject, and I think all of those things need to be really further researched and quantified.
So, how did you actually come up with this idea? Like, I'm assuming that the treatment of, say, trigger points through trigger point injection had been around for a while, but then you just took it that step further to think of, should we really be specific about where we inject based on looking at the fascial
Yeah,
sliding under ultrasound?
I think it's again thinking through something and experience. If someone pours something, did it heal appropriately? Why is it taking muscle so long to heal, and why do they feel tight? Well, they feel tight because the muscle's tight, something is stuck. And like you mentioned, fascial gliding,
Mm.
we can do a dynamic ultrasound and see if the fascia is moving appropriately or not. So it's and again, it's one of those things where every injury is a little bit different. So it just takes a little bit of experience and
Mm.
again knowledge of anatomy to know what's a safe intervention. Because last thing we want to do is is get too far into this and end up causing more problems than good, because then um, number one, it's bad for that patient in front of you and for for the athlete, but then it makes the procedure less uh, less available for people to actually improve from what they're doing. But yeah, I mean, there are a couple of early pioneers before me that I read articles about, mostly case reports about hydrodissection, mostly of nerves, and people did well from it. So it was just like, hey, this is a place I would inject normally with a blind trigger point. Let me see exactly what I'm doing, and there certainly was a pattern.
Do you have any theories as to why some people may develop some of these adhesions following a soft tissue strain while some doesn't? Do you think this sort of ties in with um, some of the issues with people's connective tissue turnover that you described before with regards to things like
Absolutely.
methylation?
So impaired methylation increases in MP2, which breaks down decorin, but then decrease in decorin apparently increases TGF beta, which then can lead to increase in fibroblasts, which then leads to increase in fibrosis, which is at least our hypothesis at this point. Still needs to be proven,
Mm,
but I've certainly seen more fibrotic development and scar tissue formation in those of hypermobile, which really makes this a paradoxical disorder because you're loose and flexible and your connective tissue is weak, but at the same time you're stiff
mm,
because of fascial adhesions and layering of fascia that we described in the paper.
mm. It's interesting you say that because I I'm a physiotherapist. When I finished studying physiotherapy, I did a 3-year yoga apprenticeship. So I implement a lot of, say, yoga-based stretching. And it's interesting when you look at hypermobile people where you feel their joint and it feels hypermobile. Yet when you actually wind up the whole myofascial system, you might start to see very significant reductions in their range of movement. And I often think about that for someone who has, say, had an injury, let's say a hamstring strain, where when you start to really wind up that posterior chain, you start to see very significant deficits from one side compared to the other. And how it has to do with not just the actual compliance and viscoelastic properties of the tissue, but again, the sliding between the different fascial layers and how that can change from prior injury or potentially due to other like nutritional or environmental factors.
Yeah, I mean it's interesting. I think that's one thing that's not really fully discussed. I mean, I think clinicians like to put things in silos. Orthopedist does the bone, and then the cardiologist does the heart, and the rheumatologist does
Mm,
inflammatory complex stuff, but nobody really looks at all of it together. And you see on the chart patients hypermobile, you just assume that they're a floppy body of gel. But it may not be the case. I mean, the back is stiff, the glutes are stiff, the hamstrings are stiff, the calves are stiff, and that doesn't mean they're not hypermobile. It's just a kind of a downstream effect of untreated hypermobility, probably from this biomechanical mechanism. There may be other factors involved, certainly. Um, but yeah, I mean, it really is
mm,
listening to the patient and not just putting people in these categories. I mean, there's some patients that we have that are extremely stiff, and but we can find areas of soft tissue fragility, or there's a history consistent with soft tissue fragility, and then they have MTHFR and they get lightheaded and have these allergy issues. So it's clean cut. I'm hypermobile and I can
mm,
do contortionist type stuff and pull my skin off my body. It's much more complex than that, and it takes someone like you to look at the joint and say, okay, your joint is loose, but then like you said, look at the probably adaptive tissue around it that's gotten fibrotic to help support an unstable joint, and realize that it's an adaptive process that in most cases is probably a good thing, but in some cases when you end up injuring fascia or people are too stiff, can cause problems.
yeah, and look, I think the other big part too is understanding that a lot of these musculoskeletal disorders are often multifactorial and require not just physical input, but potentially other lifestyle modification, and particularly when you think about dietary or nutritional input. But it seems to be that that's an area that needs a lot more work and understanding how we can change people's, say, injury risk or profile or pain and dysfunction through other lifestyle modification, because the regulation of the myofascial system isn't just got to do with mechanical load, but also other types of signals that determine how it's regulated.
Couldn't agree with you more.
Yeah. A question we like to ask our guests is there something that you're learning or interested in pursuing in learning at the moment that, and it may be related to your professional work or also may not be
I can
related
tell you
to
it's
it?
not related to my professional work because I think about my professional work all day, every day. I dream about it, and I can't go out. I can't go to the mall and see hyperextended knees and dilated pupils on TV. It's just I can't. It's very interesting. Uh, I would love to learn how to play the guitar, but I am terrible, and my
Okay.
fingers are too small and too fat. But if I could ever learn how to do that and play a couple of cool songs, then that would be great. But that would be something outside of medicine, that I'd be interested in pursuing.
Mm. Well, look, if it's any consolation, I'm really glad we've got people like you who are actually pioneering this area of work and research and really actually providing more solutions and opportunities to better manage a lot of these chronic type of conditions that we see and are very
Thank you. I
prevalent.
appreciate that, and I have a great support staff here at the Fashion Institute and Treatment Center in New Orleans that help manage, our waiting list, which we're working to get through as quickly as we can. Who are also interested in discussing fashion, learning more about it, and understanding patients when they call with certain concerns and certain symptoms, and not just really kind of writing people off and realizing that there's more to the picture. Oftentimes it meets the eye. So I certainly couldn't do this without the great people I work with, who are also just as interested as I am. So it's a really great place to be in my career, and I can't wait to pump out more research and help the hypermobile consortium get more clarity into this really common body type that really needs to be treated differently.
Mm. Yeah, well, I look forward to reading some of your future publications, and might have to try and get you on again as you start to continue to advance some of your
Yeah,
clinical
no, I mean, it's
practice and
been
your
great talking
research.
to you, and again, it's refreshing talking to someone else who kind of speaks the same language and ask questions that are certainly things that I've asked myself and tried to you know identify answers to. So that's really been a pleasure speaking with you as well today. All right,
Yeah,
take
great.
care.
Thank you. I th- Now I've just